Hello, everybody. So this is again Lenox Neurosurgery hosting another Zubinar web chat in which we discuss issues regarding COVID-19 and any questions regarding cerebrovascular disease like strokes, brain aneurysms, or any other injuries to the brain. Right now we have online Dr. Ellis from Lenox Neurosurgery, and we have the pleasure of having a special guest, a distinguished visitor to our chat, Dr. Pascal Jabbour. Dr. Jabbour is a professor of neurological surgery and the chief of the division of neurological surgery and endovascular neurosurgery at Thomas Jefferson University Hospital in Philadelphia. And on top of that, not too long ago, he became certified level 3 wine sommelier or certified sommelier, which is obviously a huge deal. And we'll have time to touch and talk a little bit about that. But first of all, welcome, Dr. Jabbour. It's an honor to have you here joining us.
Thank you, Rafael. It's my honor and pleasure to be with you, and I'm looking forward to this session.
Yes, and I was fortunate to spend some time with Pascal in Philadelphia when I was training in residency, and Pascal has grown tremendously since then. He stayed there to finish his neurosurgical training, and then completed his cerebrovascular and endovascular fellowship training over there, and became the chief of the division. Now, and I want to invite the public to write us many questions through the chat option so that we can answer to you as much as we can, and welcome Dr. Serulle, who just joined us as well. So Pascal, obviously, with the pandemic these days, there are many people that are getting sick. We have in the US alone more than 1 million people that have tested positive for COVID-19. We have more than approximately 60,000 people have died in the US alone. In New York, we have an extreme case of being the epicenter of the epicenter. In New York State, we have 300,000 cases with more than 24,000 people dead from COVID-19, and at the same time, Pennsylvania and Philadelphia being a large metropolis in Pennsylvania, you're seeing these type of effects. Last time I read, Pennsylvania had 43,000 cases with 1,900 people dying from it. Are you seeing this on day-to-day basis in the hospital in Philadelphia?
Yeah, so I can talk about the neurosurgical and the neurology part. At this point, as you remember, we have JHN, which is the hospital that's mainly dedicated for neurovascular. And we have the COVID patients overflowing from the main hospital to us. So now we have an ICU that's not a neuro ICU anymore, but it's mainly for overflow for COVID. So we've seen this, we keep on seeing it. And the problem is in this is mainly access to care. At this point, even if you want to start doing elective cases, we need to look into details like, do we have ICU beds for after we do our case, the patient can go up. There's a problem also as you know, in patients delaying coming to the hospital, and maybe we're going to start seeing more complex and severe neurovascular diseases for some patients where they needed to get treated preventively, and now they delayed, and now we're seeing problems. We already saw this in stroke patients, how they are delaying to come to the hospital, and as you know, when they do this, we have a lower chance of being able to help them and intervene. So everything is different. It's a new reality. It's a new world.
Talking specifically about stroke, as you know, there have been many reports of stroke numbers decreasing worldwide. of less patients showing up to emergency rooms with the diagnosis of stroke or stroke symptoms. Having said that, there was a recent letter in New England Journal of Medicine from the group of Mount Sinai. And I know that you have seen something similar of some increase in a sudden increase in presentation of stroke in young people, in patients that are less than 50 years old, presumably because of a role of DIC or disseminated intravascular coagulopathy in these patients. What has been your experience at Jefferson?
So as you know, there has been a lot of reports and disparities in the country in numbers. And here, because we're talking two different things, we're not saying that overall the number of stroke patients is increasing. We're saying mainly that the number of COVID positive patients presenting with stroke is high. There's a high incidence of COVID positive patients presenting with stroke. In some areas where they are seeing a decrease in stroke, I think it's mainly what we talked about. Those patients are not consulting for, they are not going to the hospital because they are scared of COVID. So what we noticed is, as I said, we noticed an increased incidence of COVID patient. Like, for example, if we look at the incidence of COVID in the population of Philadelphia, and if we did we looked at 3 weeks number, if we did an X amount, a number of mechanical thrombectomies of patient having a stroke, you would expect a certain number of positive COVID between them. But what we saw is much higher number. And we saw that around 35% of stroke patients coming to us are COVID positive. The other finding is, as we all know, that stroke is a disease of the elderly. So we found that more middle-aged and younger patients are presenting with strokes and with no risk factors for stroke. We also noticed that 50%, so this paper that we wrote, it's under review, it's about 12 patients, so not a lot. Again, I mean, I don't want to alarm everyone or things like that. It's too early to draw conclusions here, but it's something where we should be careful, and it's concerning enough to raise awareness and talk about it. So 50% of those patients didn't know they had COVID. A lot of them didn't have any symptoms, and they presented just with a stroke. It means stroke was the first presentation of COVID.
This is very similar. What you describe is very similar to the first reported experience in Wuhan, in which they did show that a significant number of people that had neurological manifestation presented as the neurological manifestation as the first symptom. And welcome, Dr. Langer, to the chat. And let's go through some questions that are being sent to us. First,
Pascal, were their D dimers high?
Yes, all of them. The common theme.
How high?
Theme was high, high D dimers.
How high?
Some of them in the thousands.
In general, what they were doing, well, at least we were doing at Lenox, was their D dimers. If they were less than 1,500, we were just using prophylaxis. But if their D dimer went over 1,500, we were fully anticoagulating. But I must say, we just didn't see it here. Now we don't have as many strokes in general as you guys. What we have seen is 3 sinus thromboses.
Yeah, well, I mean, usually, as you know, this is a rare disease, and in 2 weeks we saw 3 patients also. What we're seeing, those patients are really sick, and we're seeing more like more than sinus thrombosis. We're seeing bilateral internal cerebral veins thrombosis presenting with bithalamic infarcts, and patients that are really in bad shape.
Yeah.
So were you noticing large vessel occlusions, or were these kind of perforator infarcts?
Actually, large vessel occlusions. Mm. So, you know, one other theory is through vasculitis. Those patients are having microthrombosis, but what we've seen is more large vessel occlusion.
Okay. Yeah, and the report from Sinai, which only had 5 patients, the D dimers range from the 30s, so very low range, to 22,000.
Yeah.
So they had a very wide range of D dimer values.
It's a little odd. I mean, I know Jay saw a higher number at Sinai. I spoke to him. but we didn't. Northwell, which has a massive stroke network, hasn't.
Yeah.
So, you know, whether there's something there. I think we all know there's some hypercoagulability, you know, but that hypercoagulability doesn't always result in M1 occlusions. But it's interesting because, you know, we really haven't seen it in the Northwell system, yet Jay saw it in Sana, you guys saw it at Jeff.
Yeah, in Boston, they didn't see it too. In Michigan, they saw it. So it's, as I said earlier, a lot of disparities in the number. And I think it's because also of this, everything changed geographically. Patients are not moving. They are not going to the ER. Maybe they are going to certain hospitals. The whole network systems is all upside down. I mean, hospitals are resistant to getting transfers sometimes. So it's something different.
Yeah.
So let me read some of the questions here. We have a bunch of them already aligned. These are for the group. The first one, it says, aneurysm and AVM survivors are very worried about how they should or shouldn't be sheltering in place. Can you discuss how they should care for themselves during this very unique time? Also, we are so excited to see you all. Okay, you are heroes we love. That's what the question says. Thank you so much for the kind words, Dina. So, okay, you want to answer that, Yafell, about aneurysm and AVM survivors?
Sure. I think the bottom line here is that they should be in touch with their physicians regarding, you know, their conditions. And I think we're all available 24/7. We all have the capability of seeing patients either, you know, through telehealth and on the phone available. So I think, you know, people need to be aware that they shouldn't forget. I mean, COVID is a big thing, obviously, but there are multiple other conditions going on and they should take care of them. So be in touch with your physician and make sure you get all your questions answered by your physicians.
You mentioned telehealth, Pascal. You at Jefferson, you have had telestrokes at least for 16 years now. What are you doing these days that is a little bit different in terms of telestroke and as well as in the office? How are you seeing patients these days?
I'm going to just before that talk a little bit about aneurysms. I'm not trying to scare anyone, but we had a couple of cases where they presented, they were COVID positive after a coughing fit. One of them completely was coughing nonstop and then went unresponsive and presented with a massive rupture of an MCA aneurysm with an interparenchymal clot. So again, this is not a direct effect of COVID, but this is indirectly that, as we see sometimes patients with dissections after a coughing fit. So for telemedicine, yeah, I mean, we started actually a little bit less than 15. We started in 2009, our telemedicine here. It was really early on, and we had our neuroscience network around 35 hospitals in the tri-state area. And it was mainly for stroke. So we had robots in all those emergency rooms, and then we would log on, see stroke patients, recommend IVTPA or not, and then recommend if we would transfer. At the same time, we started doing, and this is way before COVID, post-op visits where patients live far away from us, 2-3 hours away. As you know, in post-op visits, all you need to make sure that the patient is doing well, or if it's an open surgery, you need to look at the incision. So we start doing those in telemedicine in clinic, and patients really like that. So when this pandemic happened, we didn't have to scramble or anything. We just kept on doing what we're doing, but we on a bigger scale. And at this point, we have the telemedicine through Epic that we're using, and we have the InTouch Health with robots for stroke. And this we're doing more and more. We're rounding in the ICU with it. We know that our intensivist, our intensive care team was already doing that with the ICUs of our affiliates before COVID. And here, as you know, we're not all coming every day to the hospital. It's mainly, we don't want to expose the whole team. So whoever is on call is coming, and whoever is not, we need to see our patients. So we're rounding with the robot in the intensive care unit. We're seeing the patients and then doing clinic from home. you know, sometimes it's tough to do clinic from home where you have a dog barking or something like that. So yeah.
Okay, so before I read the next question, just I don't know how much you've heard about this, but David has become an intensivist COVID-19 expert. And I think he's now debating whether he should go back to becoming a neurosurgeon again or stay being an ICU doctor. So this question goes, I'm going to ask it to David. Any comments about the FDA approval of remdesivir and also any conclusions on Pepcid that we talked about last week?
The remdesivir trial, actually, it's a slight improvement over in mortality. It was about 8% versus something like 11% in the control group. So it wasn't a massive, improvement, at least on the early review of the data. The Chinese actually believe in remdesivir as being helpful. It's not purely curative, but it's certainly helpful. You know, that the famotidine data are.
Are you aware that FDA is approving it?
Yeah, well, you know, they have to. The problem is right now is that it's like kind of like Plaquenil. It got everybody excited. You know, everybody's using it. When it's hard to take it away. You know, once it's the standard of care, and that also affects all the other trials. If you're going to do another trial, you have to give Plaquenil. And one of the problems now with the famotidine trial is patients. You just flip-flopping on hydrochloroquine. Now, when you go to consent patients, they don't want Plaquenil, but the study is designed to include famotidine and hydrochloroquine versus hydrochloroquine alone, and the patients just don't want Plaquenil because of all the negativity about hydrochloroquine. So we're not enrolling as rapidly as we did just about a week or two ago. And the same thing's happening with remdesivir now. Now that it's an incremental benefit, but now remdesivir is approved by the FDA on compassionate use. And so any further trials are likely going to have to include remdesivir and Plaquenil. And so the data start to get a little wishy-washy. You know, I think that ultimately the vaccines are the ones that are likely going to have the greatest impact. And the vaccine science is obviously incredible. This whole Oxford group's way ahead because they had a SARS vaccine and they just modified it. But long story short, I think that these therapeutics will have benefit. I think whether it's remdesivir or famotidine or, the next drug that they come up with, we'll probably see some benefit to these. And I think there will, like all the scientists say, there will be a second surge of COVID in the fall and winter. And hopefully with those, we'll hold the number of very sick patients back with some of these therapeutics.
Okay. Another question that was sent to us, is there an extra risk for someone with an unruptured AVM from COVID-19? And she continues to say, I saw reports of increased stroke risk in the brain from clotting in the lungs. Thanks. Jason, you want to answer that one about AVMs?
Yeah, sure. So far, we have not seen that. In fact, I have to say we've probably seen less ruptured aneurysms, less ruptured AVMs during this time of COVID. And potentially—
We'll go to Jefferson.
Potentially that's because people aren't as willing to get to an emergency room when they have a headache. But certainly in the last 3 or 4 weeks, there's really no evidence that this virus is causing increased brain hemorrhage. Ischemic stroke, on the other hand, I think some centers are definitely seeing, as Dr. Jabbour mentioned.
I mean, the big problem I see, and we're seeing, is this delay in people coming to the hospital. Yeah. The trouble, there is fear. I mean, I just got off the phone with a patient that we're starting to try to bring into the level 3 cases in within a week or two. And she's 72. She has a radiographic unruptured dural fistula, and she doesn't want to come to the hospital yet. She says, I'm 72. And I think there's probably an incremental increased risk of infection in hospitals, admittedly. I mean, you can't say it's safer than sitting in your kitchen. But I think if anything, there's probably more risk to just, in general, of ignoring symptoms. And that's really what's been seen. I mean, the ERs are remarkably empty in New York right now. Let's take the COVID out of it. We have fewer emergency patients in general than we've ever seen. And it's not that these patients aren't sick. It's just people just are too afraid to come, or they're going elsewhere, I suppose. But I don't think the ERs are busy anywhere. And it's I do think that, look, the lesson here is if you have a problem, don't ignore it. It's you know, you see something, say something. If you're having stroke symptoms, come to the hospital, because you know that the risk to your life and limb of having a stroke is far greater than the risk of of any symptom with COVID. Remember, COVID's still a relatively safe virus. Ultimately, on a large scale, on a public health thing, it's a massive concern. But individually, the outcomes are actually still very good, and your likelihood of doing well is high. Whereas if you're having a stroke, your likelihood of doing poorly is much higher if you just stay home. So that's really the concern we have, and I'm sure you've seen the same thing, Pascal.
Yeah, and Dave, we are worried here about when everything's gonna open up.
Yeah,
we can see a lot of sick patients because a lot of patients ignored a lot of signs and things like that, and it's gonna be a problem with also access to care, because we already now have so many backup with elective cases. So we have all those patients awaiting procedures and surgeries. And then we're going to have all the other patients that were ignoring some symptoms, and now they're going to go consult with a physician and they're going to be diagnosed with something. So it's the healthcare is going to be really flooded.
You know, the other problem is we still in New York City, I know Philadelphia, fortunately, wasn't, you know, bombed quite as badly, but our ICUs are still very full.
Yeah.
And so we have a separate
overcapacity.
What's that?
Overcapacity in the ICUs.
Yeah, we have a separate non-COVID unit, but you know, we have 7 ICUs that are COVID units, and we're maintaining the patients separately based on testing, blah blah blah. The people working the COVID units are only working the COVID units. They're not going over to the other non-COVID units to keep the hospital as safe as possible. But we don't have. If we brought all our pseudo-elective or semi-emergent cases in the next couple of weeks, we would run out of ICU beds in, you know, 1 week. And so we have to make this adjustment. I think this is going to last far into the summer, actually. At least in New York City it will, of our ability to really come back online. And, you know, we're in a brave new world. I don't think everybody's trying to be really creative and come up with different ways of doing this. The testing issues alone are problematic. Families coming to hospitals, you know, there's many issues that we're still contending with. That it's an unprecedented problem, but luckily we've all worked very hard, and we have a great organization, and we'll continue to figure our way out of this.
Pascal, talking about cases that are urgent that need to be done despite COVID-19, what are you guys doing with retinoblastomas?
So I didn't stop doing retinoblastoma. I kept on doing retinoblastoma as usual, because those babies, they would lose their eye if we stopped treating them. But I had an incident of a case where I treated the baby, and the family was with him. And then I got called the next day that the family became sick and they tested positive. And then later on, the baby developed symptoms. But we didn't stop. I think those cases need to keep on going.
The risk to children is so low.
Yeah.
It may be zero. I mean, if you look at the Italian data from Lombardy show essentially 0 children under 18. They screened a population of a town outside of Venice. They screened the population. They got about something like 80% of the population screened at the first day, and then 2 weeks later, they got about 76% screened. It was over 8,000 people. There were 0 patients under 18 that were infected, 0. And the ones that became infected at 2 weeks got the virus in the homes of people who had kids and had adults, but only adults were coming down with the virus. So, you know, it's something about being a child that prevents you from getting this infection, or at least carrying it. So, you know, I think that there should be no reason to hold off on a retinoblastoma patient. I mean, that would be crazy. Yeah.
Now, at the same time, you know, you see reports, as we were saying earlier, like we have some findings, and sometimes things happen quickly. That's why it's very important to look at trends. I don't know if you heard about the warning in UK about those kids that are presenting with like Kawasaki-like syndrome or toxic shock syndrome. Again, this is still a finding that they couldn't draw conclusions yet, but it's just they were concerned about that. So,
Okay, there were some questions here that directly asked to Pascal. And this seems to be in regards to the acute stroke, ischemic stroke patients. One said, did these patients have COVID antibodies only when they presented, or were they virus positive when they presented? In other words, are patients with ongoing infection at risk, or also after the infection? That was one question. And then they also asked, is there a relationship between stroke and COVID catecholamine storm?
So we didn't have at that time in the series, we didn't have antibodies testing. We were doing the swab, just the PCR testing. So those patients, when they came in, we were swabbing everyone, and then part of those patients, so 6 of them, we diagnosed the COVID at the hospital when they came in. One of the reasons why they are doing this, well, catecholamine storm, or the rise of the inflammation protein, the cytokine that's going to trigger the clots. So all those goes, along the same ideas.
Yeah, we have
Pascal. Sorry, you mentioned as well that you had a couple of sinus thrombosis cases in COVID patients as well,
Yes.
right?
Yes.
And from those are included in those 6 patients you mentioned?
Yes.
And did you notice, were they more resistant to the typical heparin therapy?
Yes, and they both didn't have good outcome.
The only thing I could, one bias about this, in all honesty, is that if you're taking care of the high-risk stroke patients, tend to be poorer health and from higher population density areas. And our understanding of like for example, New York City's, when they surveilled New York City, right now it's about 24% of New York City was tested positive on a surveillance. The state itself is 14% overall. New York City's 24%. I would
antibodies.
What's that? For antibodies.
In the
if you go to the Hasidic population or these really high density population in Brooklyn, it's going to be even higher. It's going to be probably maybe even 30, 40, 45%. The point is if you took all your strokes that came in, that is not really an accurate reflection of the general population by definition. And
there
so
is a selection bias, absolutely.
Yeah, and so that the reason why it's important is not that it's not worth reporting. It's just that what we have to be very careful of as physicians is that people are more anxious than they've ever been, especially when they're at home, and watching CNN all day or whatever your TV show is. It's plus with all the stuff that's happening with your kids and your family, and your life has been totally thrown into disarray, and you're just dying. And so these kind of memes begin to play a role. And so it's very important it's also, when you read statistics and you look at the data, it's important the public understands that this is not necessarily, we don't understand it quite yet and what it really means. It doesn't mean it doesn't necessarily mean that younger people have a higher risk of stroke. We don't really know that yet. It does mean that there may be a relationship between, certain populations having COVID and having a stroke, but it's not the same thing. And so, because I must think, I've thought really, you read the data and you start to see some of these relationships, and we all have to be careful because people are dying for every word. They're listening to every word we say. And so that's why the president says that people start drinking bleach. It's the same problem. So we have to be very careful.
Yeah, absolutely. And as I said earlier, we cannot draw conclusions from all of those things. It's mainly just some trends that we noticed, and mainly for awareness. And I think it's just the main message, mainly I want to put out there, and I've been putting it, is just don't ignore your symptoms. As Dave said earlier, your risk, if you're having stroke symptoms, your risk of staying at home is much higher than your risk of going to an emergency room for your stroke symptoms and catching, God forbid, COVID. So.
Right.
Here it says one question for the entire group. Were thromboelastography performed using TEG or ROTEM to identify the type of coagulopathy in your cases? I don't know if anybody here knows how to answer that. Anybody knows?
I wonder if they're referring to the cases, the stroke cases that Pascal was reporting.
No, I can't answer that. We didn't do this.
So I know that before people were mentioning about the cytokine storm, the catecholamine release, and we have seen reports of involvement in the brain having to do with this, as there has been an increase in encephalitis, in acute flaccid paralysis, in acute disseminated encephalitis during cytokine storm, as well as the increase in stroke. I know that David previously has mentioned here about involvement in the brain and maybe having something to do with the modulation of the respiratory function in the brainstem, specifically because of involvement of the nucleus ambiguous and nucleus solitarius with ACE2 receptor. Have you seen, Pascal, in Philadelphia in the ICUs, discrepancies between what's supposed to be oxygenation of the patient and how the patient is doing clinically requiring intubation versus the opposite, someone that has very poor oxygenation and is talking and seems to be completely awake and alert?
So what we've noticed is also a big difference. It depends on the patients. We really, there are a lot of things we don't know, but some patients really did poorly from a respiratory standpoint very quickly. They were setting fine, and then suddenly they started getting worse, and everything, then the cascade happens so quickly and they get intubated and everything. Some other patients were, as you said, they were still doing well clinically, but their numbers didn't look so good and they stayed like this and then they recovered. So really, I mean, there's no rules here. We've seen it all.
Okay, I see that we have more questions here. So do you see non-emergency procedures being back on the radar to do? The answer is yes, we are. We're already doing some non-emergency procedures, some urgent procedures that need to be addressed in order to prevent a stroke, to prevent a bleeding in the brain, to prevent further decompensation after a brain tumor is growing. So we're doing those. We are creating we have a safe environment in the hospitals in which we separate the staff, the ones that take care of people that are COVID positive, separate from the staff that is taking care of non-COVID people. And we're making every effort to try to diminish the risk of transmission between patients, between family members, and or the staff. Family members, for example, are not allowed in our hospitals at Northwell Health. And patients, for them to come and have and undergo surgery, we need to know ahead of time that they're COVID negative, and that has to be a test done within 48 hours from admission to the hospital, and we do repeat the test when they come to the hospital. And at the same time, we're checking for antibody testing the entire hospital staff. And these are all efforts so that people do feel that they're in safe hands and that they can come and should come to the hospital to address their potential life-altering issues. How will your staff, the interventional labs, once elective procedure resume? So if you want to answer that, Pascal?
What was the question? Sorry.
How will you staff the interventional labs when elective procedures resume?
So we're going to start practically, the decision was made recently, May 6th. We're going to start progressively. We're starting at a capacity of 50%. And then a week later, we're going to move up to 75%, then to 100%. So we're starting progressively in the coming 3 weeks. As you said, we have been doing urgent, not of course emergencies, yes, but urgent procedures like symptomatic aneurysms with massive fact, symptomatic carotid stenosis, things like that. But now we're going to expand more to the less urgent procedures. So staffing at the beginning, it's going to be, we're going to have decreased staffing, not at full capacity, and then we will increase slowly. We have been testing also all the patients, maximum 48 hours before the procedure, when they come in now for the procedure, and we're going to keep on doing that.
Dr. Serulle, what about the interventional lab at Phelps?
We're going to start staggering procedures starting next week, and we're going to follow something similar to what probably a lot of people are doing. We're going to be testing patients before procedures, and those patients who are negative, then we'll proceed. And if you're positive, we're going to try to keep the positive patients away from the hospital right now, unless, of course, it's an urgent or emergent case. And we're trying to get all of us, or everyone involved in these cases, at some point antibody tested. I don't know how, if you guys are doing that as well, Pascal, or in over there, but that's one thing we're trying to do.
I'm gonna change topics a little bit here because we already are like 20 minutes away from finishing, and it's Pascal's interest in wine. I wanna hear a little bit of how you became a wine expert and a wine connoisseur and a certified sommelier.
Well, so I've been enjoying wine for a while now.
Okay.
And as you know, it was a different type of wine that I was enjoying when I was a resident.
I bet.
Yeah. And then, you know, I've been reading about wine and I've been collecting wine. And then last year, I decided that, you know, why not? I have a lot of free time. What I'm going to do with this free time? So I decided maybe I would go to wine school and see what I can do. So, you know, I started going to wine school, and then I already belong to a wine club here, and I wanted to maybe put more science in it, but turned out that you cannot put any science in that. It's very subjective, and what everyone smells or tastes in a glass of wine is totally different, and that's the beauty of it. You can put all your imagination, and it can sometimes reflect your inner self of what type of aromas you're smelling from the wine. And you know, it's a nice thing because it's when you meet with friends, at least you can steal the conversation and talk, and everyone will listen to you.
And I know you're level 3, so that means that if you do go to the next level, you're an advanced sommelier at that point.
Yeah, after that, advanced sommelier. Yes, I started to go already courses for advanced, and then COVID happened, and now I'm in the middle of a course there. But the problem with those, you cannot do them through Zoom, because it's mainly wine tasting and things like that. So, and what we've been doing, for example, now I have a session next week for my residents. We're gonna have a session of wine tasting and wine education. So we all get the same bottles that I recommend, and then we would meet like now, and then we would do a session. I did already a session for my department, and it was fun. Did one with the Jackson Hole guys, the 3C guys. So it's fun.
Good, good. And are you more red wine, white wine, other varietals?
So interesting. Before I went to wine school, I was narrow-minded. All I drank was red, and I was like, who would drink white wine? After I went to wine school, I became more open-minded, and I started enjoying some white also. So I'm more of a Bordeaux guy. I like Bordeaux blends. I like, but also I enjoy Californian cabs. I'm starting more and more to enjoy Pinots. So I'm exploring slowly. And
okay.
Yeah.
So when this is over, we should do one of those real life sessions.
Yeah, absolutely.
Can I tell you a couple of wine stories?
Go ahead.
2 wine stories. One's my dad was and you'll appreciate this because you're like a wine guy. Yeah. My dad was a real aficionado of wine. I think he was probably about your age, in his early to mid 40s, when he really started to get into it. And in 1981, he was told by his close friend that the French wine futures were the best year ever. So he bought about almost 25 cases of first growth French Bordeaux, Margaux, Lafite, Mouton, Paubrion. We had them in our basement. The 82 vintage, which, you know, fast forward into my dad passed away in 1993. So he never drank any of it. And it was sitting in our basement. And Flam, my guy who trained me, neurosurgeon, tells me we're going to, when he asked me to go to New York with him. And so I said, well, he invited me for my wife and I, my first wife and I, for dinner to his apartment in Philadelphia. And so I said, look, I'll bring a bottle of wine with me. He says, well, what kind of wine do you have? I said, well, I have an 81 Margaux. He goes, oh, great. That's wonderful. Well, I hung up with him and I go back and looked at it because I knew nothing about wine. I go, oh shit, it's an 82 Margaux. I call him back, he goes, Dr. Flam, it's an 82. He goes, 80? You have an 82 Margaux? I was like, he goes, bring it over now. So he decanted it the day before. And that, you know, that was the first time I had any kind of wine. Like, that's just, to this day, I still have one bottle of it, actually. And we have about 6 bottles left of those, that vintage. And
when are we going to drink it?
Tell you what, Pascal, you got, if I'm going to open it for anybody, it's got to be somebody who really appreciates it. My son has taken this on. My son is 21. My second story is my son was 15 years old. He started drinking wine. He loved it. And we go in wine tasting on Eastern Long Island, and he's what was always a big kid. And the woman giving us the wine is like, I was drinking, Ben has a drink. She goes, how old are you? He goes, 15. He goes, you got to get out of here. They kicked us out of the place. So I promised him I would take him wine tasting in Napa for his 21st birthday. So luckily, I didn't procrastinate into this December, a couple months before the COVID thing. I took Ben to Napa, and we went, my favorite California cab is Paradigm. I don't know if you've had Paradigm. It's terrific. It's the woman who basically bottled Screaming Eagle, was the vendor of Screaming Eagle. She moved to Paradigm now. It's a terrific, it's not nearly as expensive, but so we went to Opus, and we went to a few other places. We went to Stag's Leap, and he's like you. He's on the track. In fact, he went to visit. He was in Europe and did a week in Bordeaux and went to a couple different chateaus. So I think it's a great thing. I heard you gave a talk at the Union League and about dessert wine.
Yeah. Thanks.
One more question, Pascal, in terms of clinical trials. For example, here in New York, we have focused all the efforts in COVID-19 clinical trials. Everything else has been put on hold for the past 6 weeks or so. Are you guys still doing your cerebrovascular trials?
At this point, everything is on hold because from our IRB here at Jefferson, we cannot consent family on the phone. And the majority of our patients here, as you know, intubated, we cannot consent them. I'm talking about the regular clinical trials for aneurysms and stroke and things like that. So they are on hold right now.
Okay. And another question, I know that you have become 100% advocate for transradial approach for endovascular procedures. Are you really doing 100% of cases transradial?
97.
Okay.
97%.
But you do attempt 100% of them, and then
I attempt 100%. So the last one that I moved into was the stroke. As you know, when you start doing transradial, you don't want to experiment with stroke, so you start doing it on all elective procedure, because in stroke you don't want to waste time. Now I'm nearly close to 98% in stroke. Now with new catheters, it's really day and night. Like now we're using a new catheter. I'm not gonna say the name because they're gonna say I'm doing advertisement, but there's a new catheter where really my fellows would tell me like, oh my God, those cases we would have to convert, 6 months ago. Here it's going, it's following, it's advancing. So really, I mean, transradial, I think, is day and night different. We looked at everything. We published on every aspect, patient risks, complications, patient satisfaction. It's really, I think, something that, everyone should.
Don't advertise catheters here. Only advertise wine. Any other questions, guys, to Pascal?
I think there was one more question there in the group. or a couple more. One asking about wine and the effects on cardiovascular health. I guess it'll depend if it's a Bordeaux or a Burgundy, right?
It depends what vintage also. So, I mean, you know, everyone knows that wine with moderation is actually good for you, or at least we try to convince ourselves. But so far, yes, I mean, one glass of wine is really good. Everyone used to talk about the French paradox, right? So the French people have all fatty cheeses and triple cream and things like that, but they didn't have cardiovascular diseases as much as here in the US. And then so turned out that red wine mainly is protective, but again, you need to watch the amount.
And there's a question here: with press discussing increasing risk for clotting issues, even from the venous system, is that any reason to consider blood thinners post-treatment? If weren't ready on them, if you were not already on them for an endovascular procedure prior to coiling for 2 aneurysms, so I guess people are asking if they should be on antithrombotics. The answer is the COVID-19 does not change the way, at least until now, the way we address issues like brain aneurysms or strokes. If someone shows up with a large artery occlusion to the hospital, we're gonna do a mechanical thrombectomy to attempt to revascularize and do workup to try to figure out why it happened, meaning checking the heart, checking the arteries in the neck, checking the blood for hypercoagulable diseases, and depending on what that shows, then that's how we're going to determine what the correct treatment to prevent another event is. And in terms of aneurysms, if someone is going to undergo a procedure that is going to require a stent or some device in the normal artery, then yes, they will be started on blood thinners, antiplatelet agents, otherwise not necessarily.
There are 2 other questions also from earlier. It says, the stroke pattern that's been observed with patient COVID include cortical or subcortical or mix? I don't know, Pascal, what's your experience?
I mean, large vessel occlusion, it's not a stroke that we see in vasculitis, distal small vessels. It's the usual large vessel occlusion.
One of the things that's definitely happening though is that the imaging, frequency of imaging, if you come in with an LVO and you come in with a hemiplegia and a high NH stroke score, you're getting imaged, then you're treating your stroke and you're finding out about COVID later. Mm-hmm. So, but COVID patients who already are sick with COVID in a unit are having neurological manifestations of their COVID infection, whether it's early from cytotoxic storm or as a result of toxic encephalopathy or a combination of everything. But we're not studying these patients up until recently. We weren't studying them because we just couldn't afford to move the patient down to get a scan or take them to the magnet. We have a portable CT, but even that we weren't using just because the PPE and the amount of nursing and exposure. Plus, there's nothing to do anyway if a patient had a deficit necessarily in these patients. So I think the answer to that question is I don't think we know yet. I think it's been by report there have been subcortical strokes. The ones that we picked up associated with COVID were the cortical strokes, the LVOs. But I think we probably will see going forward more, subclinical strokes as we study these patients more closely.
And what the last thing, also something important, and those patients that were already sick with COVID and intubated, those are patients with a problem where they are sedated, paralyzed, sometimes prone. It means they are on the belly. And in those patients, we've seen a couple of them where, you cannot wake them up to examine them every hour. Those patients are buckling on the vent. You need to ventilate them. You have priorities. And those patients, when they are developing strokes, it's too late. This may be, and again, I don't know. So one of the most common questions I had after I was on CNN, people were like sending me, is about, should we be on blood thinners? Should we be on things like that? I think if there's any, and this of course needs a trial, but if there's any category of patient that may be on this or may be candidate, are those patients that are sick, intubated, where you cannot examine them. At that time, maybe prevention, putting them on something would help. But again, all those are speculation. There's no official recommendation yet.
There's also a question about the other coagulation diagnostic tests that appear to be correlated in addition to D-dimer. I'm not really aware of any. D-dimer is really not a coagulation diagnostic test. Obviously, it's just a serum inflammatory marker.
Yeah.
And all the inflammatory markers go up, actually, pretty much every single one in the cytotoxic storm. But as far as coagulation, like the typical, you know, protein A, protein C, all that other PT, PTT, whatever you're testing, I'm not aware of anything that changes due to COVID specifically.
No, and all those patients, they got a hypercoagulative workup as usual, and nothing stood out other than what you mentioned.
So how's Philadelphia been? Has it been, what percentage of units are COVID? Has it been, obviously it's not.
Yeah, before you logged on, I was saying now, you know, we have JHN, the Neuroscience Network, so we have some overflow COVID from the main hospital. So I think at this point it's been decreasing slowly, and I think we're in a better shape. So
that's great.
Okay. Anybody else? Anything to add? Okay.
So does an AVM have a greater risk of having a stroke of them? We already answered that question, right, about AVMs. So I don't think so. We don't think so. So.
Okay, well, Pascal, pleasure. Great seeing you. Thank you for
being on national TV also, Pascal. I mean, you know, I thought it was going to be Mako, and it turned out to be you. That was awesome.
You like that? Well, you are a Netflix star, and all your group, right?
Coming.
Coming.
We're going to set the world on fire in about a month.
June 10th.
Well, when you're on Netflix, just say hi to your old friend in Philadelphia.
We'll do another Zoom conference after that.
Okay. Thank you, guys.
All right. Thank you for having me.
Yeah.
Take care, Pascal.
Thank you, Pascal.
Thanks, everyone.